talk about patient-reported outcome measure and patient-reported experience measure. As my colleague previously said, I am Marie-Ève Poitras. I am a researcher and a professor at Sherbrooke University. I also have a research chair on the optimization of professional practice in primary care. But since 5 years, I am also the co-lead of the Paris OECD project, which is interested in PROMs and PREMs integration in primary care. So some primary care practice in Alberta has been involved in Paris initiative, and I'm really happy and excited to tell that the international result and Canadian result has been launched early this morning. So report and flagship report will be open access and available in some hours. So first of all, we just want Veronique and I introduce a little bit ourselves and to explain how this project and the project that we present during the Journal Club today is really embedded in our research program. As a primary care researcher and Paris OECD co-lead in Canada, I developed an interesting expertise in PROMs and PREMs integration and patient-oriented research integration in primary care and in healthcare system. So in my research program that we are conducting with patient partner and interdisciplinary team member, mostly in primary care, we have several research initiatives where we are trying to integrate patient-reported outcome measure, patient-reported experience measure also in primary care, but also the patient-oriented research perspective and best practice in different research team and healthcare organization. So Veronique, it's up to you to present your background and your research program also.
Hi, everyone. I'm really pleased to be presenting today. My name is Veronique Lowry. I am a physiotherapist and assistant professor at the University of Montreal, but I worked on the project we are presenting today while I was a postdoc fellow in Professor Poitras' team in the chair on optimal practice in primary care. My research program at the University of Montreal aim at optimizing access, quality, and continuity of care for adults living with musculoskeletal pain in primary care. My research is really focused on improving practice and improving the experience and outcomes of patients. I have three main themes in my research program, which is the development and implementation of interdisciplinary primary care models to improve healthcare access for adults living with MSK pain. I also aim at implementing strategies to facilitate an evidence-based management of adults living with MSK pain in primary care and to promote adapted physical activity for adults living with chronic MSK pain in primary care. And we're going to start the presentation. I'll let Marie-Ève continue.
Thanks, Veronique. So today's plan will be similar to other journal club that you have already attended. So we will talk about the context, objective. We will present quickly our method without burning. And after the result, and we will enjoy a discussion with you. So we can wait to hear you about your perspective about PREMs and PROMs and how it could be used or integrated in primary in different care setting. So next slide, please. So this project is mostly based on, could you switch slide, please? Thank you. So this project is based on value-based healthcare, so patient-centered approach, where it's important to mention that when we start this project, it was the early beginning of Paris OECD project, so in Quebec and also in Canada. And we observed that when we were questioning primary care professional, healthcare organization or patient partners themselves or patient partner organization, they were always asking us about what is PREMs, and they didn't know about this new measurement, this new concept, and we were we realized that we are talking a lot of new language. So before starting to do the Paris OECD project, we were interested. The research question highlight in our head was why people doesn't know what we are talking about when we are talking about PREMs and PROMs. And we observed that if they didn't know what we are talking about, how we will be able to integrate, measure, and use PROMs and PREMs data. So we take the first step of consulting primary care, healthcare professional organization and patient partner or patient representative organization to asking what they know about PROMs and PREMs, because we were interested about the level of integration and the level of knowledge about PROMs and PREMs. Why? It's because patient organization and healthcare professional organization most often rule and direct the professional practice, but also guide the patient partners or patient that have received care in the healthcare system. So we were interested about what do they think about PREMs and PROMs, what is the integration level of PREMs and PROM in those organizations, and how they master the concept. And after we did the hypothesis that depend of the level of integration of those organizations, it will raise some red flag about the work that we have to do to support Paris OECD, but any other initiative which will have the goal to integrate PROMs and PREMs. So this project is really integrated in value-based healthcare, and what we are interested in is the value given by the care that patient receive, but also we want to hear patient, and we value patient perspective and patient experience of care. So patient-oriented, patient-reported outcome measure, so PREMs, and patient-reported experience measure, PREMs, are really useful to support value-based healthcare, but are the only validated measure, self-report measure that a patient can only answer without the interpretation of a third party. So it's a really interesting and useful tool and data sources that we can use in the healthcare system, but also in research initiatives to hear patients and to receive quantitative feedback about perceived health and perceived experience of healthcare. Next slide, please. So PREMs and PROMs could be really useful at different levels of the healthcare system. As an example, PROMs could support the point of care level. So when a patient and a healthcare provider use the PROM score to orient the intervention and to monitor the health status or quality of life of a patient. PREMs could also support decision-making or communication between a practitioner and a patient during an encounter or in the care pathway. And it's a hard one for a francophone person, but at an organizational level, or systemic level, PROMs and PREMs could be used as an aggregate data sources in dashboard, and could facilitate organizational or political decision making and people are able to identify or target what patient, what group of patient, what characteristic of the patient could be prioritized to support healthcare decision, policy making, or service organization on jurisdiction, by example. Next slide, please, Veronique. So the implementation of PREMs and PREMs are in usual care, however, remain scarce and variable, one setting one another. I know that Alberta is in advance in some practice and in some sector in terms of implementation of PREMs and PREMs. We know also that PREMs, as an example, is mostly used in oncology sector, but also in the orthopedic sector. But at the time when we begin Paris OECD, 5 years ago, PROMs and PREMs were at the early stage of development in primary care sector and only at research level or clinic or practice level in some instance. What we observe also when we are talking about the PROMs and PREMs science and PROMs and PREMs implementation, we observe that there is some PROMs that they are used with EMR data, but it's not systematized among a lot of practice, and most of the time experience of care is not documented at all, or small, it's really little document in different practice. What we know also is decision maker do not have access to PROMs and PREMs data sources has another data sources to orient shared decision-making, policy decision-making. Next slide. So in this way, we were interested because I talk about different perspective here, but we were really interested about to describe the current knowledge and use of PROMs and PREMs by healthcare professional and patient organization in Quebec, because those two kind of organization are really strong to orient one professional practice, patient advocacy, but also service organization at provincial level or for the patient perspective. So they were the first instance, the first organization both that we asking about the level of integration of PREMs and POMs. So during this scan, we were also interested to describe the determinant of PREMs and PROMs implementation and the level of use or knowledge about PROMs and PREMs in those organizations. Veronique, it's up to you.
Okay, so we to achieve this goal, we conducted sorry, it's a hard word as well, environmental scan to understand the current implementation of PROMs and PREMs in Quebec. We did there's various ways to do an environmental scan. But we used semi-structured interviews to explore the point of view of healthcare professional and patients organization regarding to the use of PROMs and PREMs in healthcare, as Maria said. And we addressed with this semi-structured interview guide, we addressed different themes, which are current practice of the organization regarding the use of PROMs and PREMs, so how they use it right now, if they are aware of it, we're going to see if it's the case. We also asked them about the tools that are used for measurement actually in their organization. We also asked them about the potential benefits of PROMs and PREMs and their views about the challenge that are faced and visions for implementing PROMs and PREMs in the future. So the steps we used to achieve our goals were the following. First, we identified the potential healthcare organization, healthcare professional organization, and patients organization on the professional orders office. And we use also a Google search. Then there was a first sorting of the organization by the research assistant and a second sorting by a team constituted of researcher, healthcare professional, and patient partners, which resulted in a final selection of eligible organization. We then invited the organization by email or by direct solicitation within our patient partner network, and we conducted interviews with 19 representatives from the healthcare professional organization and 9 patient organization. We audio coded the interviews, and we analyzed the interviews using an inductive and deductive thematic analysis. The deductive analysis was based on the Franklin framework, which is used to guide the collection and use of a patient outcome measure in the learning health system. And then finally, we presented the results related to the implementation status of PROMs and PREMs in the organization and barriers and facilitators to using PROMs and PREMs. So we identified 22 patient organizations. 19 organizations were identified from a Google search, and 3 organizations were identified within our patient partner network. All the organizations were eligible to participate, and we finally received answers from 9 patient organizations, which we interviewed. Regarding the healthcare professional organization, 74 organizations were identified. 28 were professional orders and or boards, and 46 were professional associations. Within them, 44 healthcare professional organizations were excluded because they were not susceptible to be integrating PROMs and PREMs. And from the 30 eligible professional organizations that were contacted, 19 accepted our invitation and were interviewed. Our interviews lasted between 20 and 40 minutes, and I'm gonna talk to you about the result from these interviews. So after our qualitative analysis, we identify different perspectives of healthcare professional organization regarding the implementation of PROMs and PREMs within their organization or in the clinical practice of members of their organization. So usually the person we interviewed was a professional as well. So the representative from healthcare professional organization, they mentioned that they were familiar with the concept of patient perception, that the concept of self-reported measure was familiar too, but they were mostly not aware of specific PROMs and PREMs tools, and they didn't know the vocabulary that we use. As one representative mentioned, the more formalized and standardized self-reported measure, yes, that is new. So they knew that this concept existed, but it didn't knew the formal one. They also mentioned that incorporating formal PROMs and PREMs was not a commonly adopted practice by healthcare professionals that were members of their organization. They mentioned that members know that PROMs and PREM exist, but that it's not a practice that is adopted. However, as they were not really aware of the PROMs and PREMs, but the representatives, from the healthcare professional organization, they mentioned that PROMs and PREMs needs to be shared within the members of their organization, and that there is a need to integrate more patients' point of view into clinical practice, which is a good thing. So one of the citation we have is we have to stop being paternalistic. Patients are increasingly educated and knowledgeable about therapy. They have questions, requests. We have to change our attitude as professional. We can no longer have the I know what's good for you attitude. The organization's representative reported also that PROMs and PREMs, as well as patient perception, should be integrated in undergraduate training and in continuing professional development, which is not really done at the moment. One of the representative mentioned that there was some sort of PROMs used in the undergraduate training. But most of them, they mentioned that improving the skills must be done through initial training. Initial training is not suited to this approach right now. It would be interesting to develop training or clinical practice guidelines. So that's it for the healthcare professionals organization perspective. Now, in the patient organization perspective, the concept of PROMs and PREMs appeared new to most patient organizations. They indicated that they perceived their role as more related to listening and supporting patients than to have formal data collection and data analysis. One representative mentioned that the primary role of the association is to listen and support our members, then to establish the needs and priorities of the members. We organize coffee meetings. So they were organizing more less formal call it data collection. Another representative mentioned it is not usual for professional to include patients' perspective. It's a more paternalistic approach that we encounter with the majority of the profession. From our interviews, we also found that including the patient perception is very professional dependent. So one patient organization representative mentioned pivot nurse and nurses are great at integrating the patient experience. Specialists are more difficult. On the other hand, young people are often more human and open. What else is the patient partner offices in hospital? There is room to enhance the patient partnership approach. However, it's extremely dependent on the professional. And finally, some patient organizations were reluctant about the implementation of PROMs and PREMs as they feared that the overuse of questionnaire could lead to depersonalization and dehumanization of practice. One of the representatives mentioned, I hope that new practices will be used to enhance the quality of care, not to enhance the dehumanization and depersonalization of care. We were also able to identify facilitators to implementing PREMs and PROMs according to healthcare professional and patient organization representative. So some of the facilitators to implementing PREMs and PROMs according to healthcare professional organization include providing adequate training to professional, allocating some time for analyzing the data, to provide clerical support for data management and for administration and compilation. And another facilitator would be to make the use of tools a governmental standard. So it's a higher level strategy, but that's really interesting. And according to the patient organization representative, facilitators included explaining to the patient the importance of filling out the questionnaire instead of just give the questionnaire to them, using a digital platform to collect data and providing various data collection methods to promote equity, such as using paper questionnaire, digital questionnaire, and having the possibility to complete it orally with someone who's gonna collect the data. And both healthcare professional and patient organization, they mentioned that providing a short and simple questionnaire, demonstrating the added value of the tool, and including the tools in the EMR would be facilitators. On the other hand, there were barriers that were identified to implementing PREMs and PROMs. According to the healthcare professional organization, there is a lack of awareness and availability of the tool. So we saw that some healthcare professionals do not know that these tools exist, and there's also barriers in terms of language and the fact that some tools are not open. They don't have open access. There is also an inconsistency of the digital platforms used by healthcare professionals, so it's hard to have a standardized way to collect the data. There is also a lack of time, a lack of financial, technological, and staff resources that are barriers to implementing the PROM. And there's also a fear that adding new questionnaire will add administrative burden, which is really present, and reduce time for clinical activities. And according to patient organization, they mentioned that a barrier is that the data is not integrated on the platform accessible both by healthcare professional and patient. And barriers that are present in both organizations are some resistance to change and a lack of motivation for patients to complete the questionnaire and a lack of motivation of healthcare professional to explain the questionnaire. So in conclusion, healthcare professional organization, they acknowledge that the importance of evaluating patient perception, but they do not use validated PROMs and PREMs. Instead of validated tools, they use in-house tool usually, which is a problem because of the validity and the reliability of these tools. Healthcare professional organization also receive insufficient information about the usefulness and availability of the tool from organization, but also in their training. And patient organizations are also largely unaware of PROMs and PREMs, but they recognize their potential benefits for disease management. However, we saw that they were a little bit more reluctant with the PREMs and PROMs. They feared that the implementing PREMs and PROMs will not necessarily represent the interest of patients. And just to summarize the barriers to implementing PROMs and PREMs, there are some at the healthcare professional level, which is like the lack of awareness, the lack of training and ability to interpret PROMs and PREMs data. There's also, as I said, a fear that PROMs and PREMs would increase workload and reduce care quality. We also see that the patient engagement depends on clear explanation and discussion of results. So there is really something with the interaction of the professional and the patient to make them motivated to fill the questionnaires. There are organizational challenge as well, which are the lack of resources and funding. And we also see that the government support is crucial for widespread adoption and standardization of the implementation, and a need for training in academia, in the undergraduate training, and also in the continuing education for professionals. So before we start our discussion, there was a few strength and limitation from our study. So the strengths are that we did a really comprehensive snapshot of the implementation of PROMs and PREMs in healthcare in Quebec. We were able to gather a diverse range of perspective from healthcare professional and patient organization, which ensures relevance and authenticity with real-world insight. We were also able to identify determinants and opportunities that can guide future strategies for better implementation. In terms of limitation, as a lot of qualitative studies are, there are some social desirability bias or individual perception that may have influenced the interviewee responses. There is a limited generalizability as the study focused on specific organization in Quebec, Canada, and we're going to talk about it in groups after that. The study was conducted, like Marie-Ève said, in 2021, 2022. It was the PROMs and PREMs were less integrated at that moment, so some findings may be outdated right now due to rapid change in healthcare practice. And we see, I don't know if it's really a limitation of our study, but there is, despite healthcare organization intend to implement PROMs and PREMs, there are still barriers that limit their use. So thank you very much, and do you want to start the discussion, Marie-Ève? We have the question, but I believe it would be better if I don't share my screen.
Maybe we can just put the question in the chat and stop sharing the screen.